Potassium is the major intracellular cation found primarily in muscle, liver, and red blood cells. It helps with nerve conduction, muscle function, acid-base balance, and protein synthesis. Potassium really helps to regulate the heart, influencing rate and force of contraction. Therefore, even minor changes can have major effects, especially on cardiovascular rhythm. A normal Western diet gives us around 70 millimoles of potassium per day, and the intestines absorb almost all of it. The liver processes it before systemic circulation. Excretion occurs almost entirely through the kidneys, with only a small amount getting lost in the feces. Because the kidneys regulate potassium so tightly, any renal dysfunction could lead to a dangerous imbalance a potassium balance is influenced by several factors. Aldosterone promotes potassium excretion in exchange for sodium reabsorption in the renal tubules. Acid-base balance also matters because alkalosis drives potassium into cells, lowering serum levels, while acidosis causes potassium to shift out of cells, raising serum levels. This makes potassium especially dynamic, as a single lab value may change quickly depending on the patient's physiology. We can see here some of these drivers now in the kidney, as well as these cells. Potassium concentration in plasma is influenced by multiple mechanisms. Aldosterone increases potassium loss in the kidneys, while sodium reabsorption in the renal tubules promotes potassium secretion to maintain electrical balance. Acid-base status also matters. Again, alkalosis reduces potassium in the serum, while acidosis increases it. Because potassium is regulated, an imbalance can affect neuromuscular and cardiovascular function. In a normal adult, serum potassium levels are listed as 3.5 to 5.2, optimal levels between 4 and 4.5. Children, infants, and neonates have slightly different ranges, usually a bit higher. And critical values are anything under 2.5 or greater than 6.5 to 8, depending on the lab. And these critical values signal a life-threatening risk, such as arrhythmia or cardiac arrest. And this is why it's one of the most closely monitored electrolytes in medicine. Several factors can falsely alter potassium. Hemolysis during phlebotomy will release potassium from red blood cells, which falsely elevates levels. If blood cells sit too long before separation, the potassium can leak into the serum. Even having a patient pump their fist before venipuncture can raise potassium, especially if the tourniquet is on. Because of these risks, potassium is highly sensitive to collection technique. Minor changes in potassium then lead to major physiologic consequences. This is why it's closely monitored, especially for critically ill patients and is on diuretics and cardiovascular medications. Both hypokalemia and hyperkalemia can cause arrhythmias, muscle dysfunction, and therefore keeping potassium in range is essential for patient safety. Hyperkalemia is defined as a serum potassium level is greater than 5.5. There's lots of causes here. I've listed some on the slide. It can also be triggered by acidosis, where hydrogen shifts into cells and potassium shifts out. Even exercise can cause transient rises. And the key point is that high potassium is potentially life-threatening and therefore requires urgent management. Early symptoms to hyperkalemia could include paresthesias, muscle twitching due to increased excitability, and as levels rise, muscle weakness and flaccid paralysis occur. The heart is particularly vulnerable. EKG changes, dysrhythmias, bradycardia, heart block, and eventually cardiac arrest can result. This is why rapid recognition and treatment of hyperkalemia are crucial. And we can see here the relationship of hyperkalemia and the different processes and evaluations below. On the other end of the scale, hypokalemia is any time potassium is below 3.5, and it can result from decreased intake, increased loss, or shift into cells. Diuretics are a common cause, as are chronic vomiting, diarrhea, or trauma. Acid-base influences also play a role, as alkalosis drives potassium into cells, lowering serum levels. And in diabetics with ketoacidosis, potassium may be lost in the urine as hydrogen ions replace it in the cells. Specific causes can include diuretic therapy, stress, trauma, meds, etc., and a redistribution between intra and extracellular compartments, such as during alkalosis or insulin therapy, will also lower serum potassium. Because causes are varied, interpreting this requires looking at clinical context. There's a wide range of clinical effects for hypokalemia. Neuromuscular symptoms, including weakness, flaccid paralysis, and severe cases, respiratory distress. Cardiovascular manifestations are huge, including arrhythmias and postural hypotension, the classic U wave on EKG. Other effects include glucose intolerance, constipation, and even renal impairment. Importantly, reducing potassium correlates with higher blood pressure, both in normotensive and hypertensive persons. Here's a flow sheet here. When we come back, we'll discuss magnesium.